started. Thank you so much, Elizabeth. All right, Joy, I'll share my screen and pull up your cases. So I have two of them. Are you okay starting with the one I have pulled up here?
Yes, that's perfect. Thank you.
So, thank you. I'll turn it to you now.
Okay. If you don't mind scrolling down just a bit. So I'm also the medical director of our COpAT program. So starting out with a COpAT case, and our session today is on endovascular infections. So this patient is a 33-year-old male. And I'm going to start with a history of present illness. He presented with fevers, body aches, headaches, and fatigue that had been going on for approximately 2 months. His blood cultures grew Streptococcus aeruginosus in 4 of 4 bottles. So high-grade bacteremia with clearance of bacteremia achieved pretty quickly on October 20th. Transesophageal echocardiogram on October 23rd showed a bicuspid aortic valve with a subaortic vegetation that was about 0.4 centimeters in size and severe aortic regurgitation. And he underwent aortic valve repair and descending aortic root replacement on October 26th. And operative cultures were positive. They grew Streptococcus aeruginosus. And at the time of evaluation, he was receiving ceftriaxone. So moving up to which antimicrobial therapy and why, I want to propose amoxicillin 1 gram by mouth 3 times a day. And the reasoning is this is a native aortic valve endocarditis from Streptococcus aeruginosus, which is Viridans group Streptococcus, and was a sensitive strain. So penicillin MIC was less than 0.6, ampicillin MIC less than 0.25. So kind of moving on through this case, surgical history, he did have medical and surgical history. He did have a history of a heart murmur, an aortic aneurysm, as well as hypertension. His medications really are not contributory, no known allergies. And he lived alone, was employed as a driver for FedEx, and no real substance use history, just occasionally vaped. So in physical exam, he was evaluated preoperatively. He was afebrile, appeared non-toxic, irregular rate and rhythm, had an aortic regurgitation murmur, and then was found to have a splinter hemorrhage on his left fourth finger. Maximum CRP was 83.3 at the time of evaluation and had already started coming down to 28.5. It keeps going down. You can see all of his microbiology data here. So I kind of went through this already. I'm not going to repeat, but just blood cultures, again, grew strep aeruginosus or Viridans group Streptococcus. And then operative cultures were also positive for the same organism. We talked about his imaging already. And at the time of evaluation, he just had a peripheral IV line. So questions for the group, is early intravenous to oral antimicrobial therapy transition appropriate? Is this someone who you would transition to oral antibiotics to complete treatment? If yes, when would you consider transitioning to oral antimicrobial therapy? Do we need an IV induction? Are we comfortable transitioning as soon as he's stable postoperatively? And how long would you treat this patient and why? So does anyone want to start with the first question? Do you think this patient who had a big aortic valve surgery, operative cultures positive, is he somebody that would be a candidate for early transition from IV to oral antimicrobial therapy?
Thank you so much, Dr. Jeskowicz. Great case presentation. And yeah, I'll let folks think about any comments, questions regarding the case, or if they have recommendations. I'm happy to also pull up the case again if anyone needs to refer back. Just let me know. Yeah, everyone's welcome to chime in. You can unmute or you can chat in the chat box and I can read it out loud for you. I pulled up the case again, so anyone can refer to the questions that were asked.
So this is a left-sided endocarditis, right, native valve. Drew's going to touch on this later in the presentation, right? But we have a landmark study from the New England Journal of Medicine 2019, the POET trial, that had several hundred patients and showed that early transition from IV to oral antibiotics after a minimum of 10 days was non-inferior to continuing IV antibiotic therapy. So would this patient fit into that category?
Any thoughts from the group? You're welcome to chat in as well.
Dr. Sawari, what do you think?
If you had asked me this question many years ago, I would have said probably not. Most of us have been taught that infective endocarditis is best treated with intravenous antimicrobials. However, the trial you're referring to was, from my perspective, a game changer and a landmark trial. And it kind of helps me recognize and realize that bugs usually don't care how you get the antibiotics to them, whether it's intravenously or orally. And so long as the basic pharmacological principles of a peak serum concentration about 10 times the MIC, that basic science principle is held, then you should certainly be able to treat this with oral antibiotics.
Thank you.
Thank you so much. Any thoughts from the group on that? You agree, or anyone have a similar case that they've seen? Right, and
So we did propose an oral antibiotic regimen, right? So amoxicillin 1 gram by mouth 3 times a day. Kind of another question here was, how early would you transition? Is this something we could do on discharge? So we're learning that patients are doing well in earlier and earlier transition. This patient was discharged with amoxicillin with a plan for 4 to 6 weeks of antibiotic therapy postoperatively, and he was transitioned to oral antibiotics 72 hours postoperatively. So really, as soon as he was stable down in the CVICU, he was transitioned to amoxicillin. It was subsequently extended from 4 to 6 weeks, the longer end of our duration, to allow CRP normalization. And CRP at the end of his antimicrobial course did normalize at 4. So he responded very, very well. And he recently participated in follow-up in ID clinic approximately 3 months after his surgery and hospital discharge, and after being off antimicrobial therapy for approximately 6 weeks, and continued doing very, very well. Just wanted to just share that case. And since we may have a few extra minutes too, I just touched on the POET trial. But again, now we have 5-year outcomes of the POET trial that have shown that patients that were transitioned from IV to oral antibiotics early actually had higher survival and no indication of longer-term treatment failure. So this patient is an example of a patient that fits into the POET trial, and now we have 5-year mortality data that this works, and it's actually safer.
That's so incredible. Thank you for sharing that. That's very interesting to see.
Anybody else have any comments?
I think, as we begin to implement and hopefully change practice, we begin to recognize and realize that this is kind of a win-win-win. Patients love the opportunity to leave the hospital without a PICC line. They do well. The institution loves the opportunity to discharge patients earlier. That decreased length of stay interprets into their own metrics. And then in general, especially for a rural state like West Virginia, I think you get an opportunity to, without compromising outcomes, provide pretty good quality and standard of care with earlier transition from IV to oral.
Thank you so much, Dr. Sawari.
Mitra, if you don't mind, can I pose a question to the group just to gauge a sense of where we are?
Absolutely. Yeah.
most of us are uncomfortable with a scenario like this where we are switching from IV to oral. Is there anyone in the group who would say they are at the moment very comfortable switching?
You can give us a like in the chat.
That's a great point. Yes, you can use the reaction feature. Uncomfortable or comfortable switching? Your thoughts on it? No thoughts from the group?
Yeah, quiet group today. It's about interacting.
How about any of our pharmacists that have rotated and spent some time with me on COpAT, and Dr. Story too?
Hey Joy, can you hear me?
Yeah.
Yeah, in this case, it's definitely with, some experience behind us now. I think it is a patient that I would feel comfortable with the presented plan. But just as just in my couple of years of practice here, it's changed quite a bit from the beginning of our COpAT program implementation to where we are now in terms of, I think, not just my comfortability, but with our hospital and providers' comfortability as a whole.
Thank you.
Thank you, Drew. And David chatted and saying, think it is more dependent on physician risk tolerance. Thank you for chatting that in, David. And if
I think you bring up a very good point, David. Physician risk tolerance, or my own risk tolerance, I can understand and adjust for, so long as it is not compromising patient care in terms of IVs being more dangerous. And I think that's a paradigm shift. We've kind of been taught that for some serious infections, IVs are the only option, and that's the way to go, ignore their consequences. And I think I need to work harder at my own risk tolerance and at least stay up with the literature that is starting to say, recognize that there is an easier, safer, and better way to treat these infections rather than IV.
Thank you so much. And any other comments or questions from the group about this case or this conversation? David, thank you. Hard to make the first step for change, but once you get comfortable, it is more likely. Absolutely. Thank you, David. Any other comments from the group? We have the other case as well. We can always go into that one, but I don't want to rush anyone. So there's more about this case. Please do chime in. All right, and Dr. Juskowicz, would you like me to pull up your second case? We can get into that one.
Does the group think we have time?
Yeah, we could absolutely save it for next time, or we can get into didactic as well.
You can pull it up. It's okay. Thank you.
Awesome, absolutely. All righty. Are you able to see that okay?
Yes.
Okay, perfect. I'll turn it to you. Thank you.
Okay. So this is the second case. And after this case, I'm going to have Dr. Sori ask the same question. In this patient, how comfortable would you be treating with oral antibiotics? So this patient is a 23-year-old female. And you can scroll down just to the history of present illness. And I know this is a big paragraph, so I'm going to kind of hit some main points and try to summarize that the patient's a 23-year-old female with a medical history of injection drug use, opioid use disorder, came in with fevers, chills, shortness of breath, and malaise. And she had a couple hospital admissions. So she was initially admitted at Princeton Community Hospital, end of July, beginning of August, when blood cultures grew MRSA. For those of us in ID, vancomycin MIC was one. Blood cultures did clear transiently. At that time, she also had left loculated pleural effusion empyema, underwent a thoracentesis when sterile site culture grew MRSA. Had a transthoracic echocardiogram that showed a tricuspid valve vegetation. And she was given vancomycin, had difficulty reaching therapeutic levels, and so was switched to daptomycin. And initially, she felt uncomfortable, felt a little bit of stigma, I think, associated with her injection drug use, and left against medical advice. But did come back to Princeton Community Hospital, where she stayed for another 2 weeks in August. And blood cultures, again, from August 6th to August 19th, this time grew MRSA with vancomycin MIC2, so starting to increase. She did have a PIC inserted that was left in for a period of time in the setting of bacteremia. Had a repeat transthoracic echocardiogram that showed tricuspid valve vegetation. Now we have dimensions, about 1.3 centimeters in greatest dimension with moderate to severe tricuspid regurgitation, and a CTA of the chest that showed progression or septic pulmonary emboli that were worsening from prior imaging that she had early on. So she was receiving daptomycin, transferred to Ruby Memorial Hospital, where she remained hospitalized from August 20th to September 15th. Blood cultures at Ruby from August 20th to August 24th. So had really been bacteremic now for over a month. Grew MRSA, vancomycin MIC 1 to 2, daptomycin non-susceptible. Did clear her blood cultures on August 26th. Had repeat echocardiogram and CT of the chest that showed similar findings that had previously been demonstrated. So she underwent bioprosthetic tricuspid valve replacement on August 29th when operative cultures grew VISA. So what's VISA? It's kind of like MRSA, but a Staph aureus with a vancomycin susceptibility intermediate, and also daptomycin non-susceptible. So she was treated with vancomycin and ceftaroline that was de-escalated to ceftaroline monotherapy, and she was receiving that at the time of evaluation. So which antimicrobial therapy and why? We're proposing linezolid and rifampin. The reasoning is because linezolid has excellent MRSA coverage with high 100% bioavailability. Rifampin is useful in the setting of prosthetic material, so she had had a bioprosthetic tricuspid valve replacement. And against biofilm formation. So you can keep scrolling down. So kind of a complicated case, but basically a young female with injection drug use who had an MRSA, tricuspid valve endocarditis, septic pulmonary emboli, left empyema, and had increasing resistance to antimicrobial therapy, eventually underwent a tricuspid valve replacement and had positive operative cultures. So this is her past history, just additional pertinent history. Hepatitis C virus infection, and then some mental health issues. Medications, this could be important for interactions. So Suboxone and venlafaxine in this case, would both have potential interactions with linezolid. She would require counseling. No known allergies. Lives in Princeton, has a family, including young children. And then kind of going down to her physical exam. So she was afebrile at time of evaluation, but when she was transferred to Ruby, her temperature had been 40 degrees Celsius, so very ill. At that point, regular rate rhythm, no murmur, and did still have some decreased breath sounds of the left lung base from kind of a resolving left empyema, loculated pleural effusion. Sternotomy incision was healing well. So maximum CRP was about 270 at the time of evaluation. If you scroll down, it had decreased to about 64. And these are her culture, or this is her culture information that I've already gone through. Okay, keep scrolling down, please. Thanks. And surgical pathology was consistent with endocarditis. She had already had a PIC placed in her right upper extremity. So just a few questions about this case. How would you summarize this if you were going to give kind of a one-sentence summary of her diagnosis? And I've kind of already done this for you. Is early intravenous to oral antimicrobial transition appropriate for this patient? And what are some things we can learn from this case?
Thank you so much. Another great case presentation. I'm sure a lot we can discuss about this as well. But yeah, I'm happy to pull up the case again with the questions if anyone would like to refer back. But initially, any thoughts from the group? Thoughts about the case, not even necessarily about the questions, if you just have thoughts that came to mind while listening to this case. Welcome to chime in. I'll give it a long echo pause.
So Ari, do you want to ask the same question about their comfort level in compared to the first case or in general?
So in this case, I think we're now dealing with substance use or injection drug use associated. And does that make you more or less comfortable with oral antibiotics?
Anyone in the audience or group?
You're welcome to chatting as well, like David did with the other case.
So in her particular case, she did end up getting 2 weeks of IV antimicrobial therapy postoperatively with the ceftaroline. And she received that on our multidisciplinary infusion service, where she also got psychiatric care, was able to participate in at least individual therapy in her case, and was started on a Suboxone. So I was able to start that in the first 2 weeks of treatment. There was a chat before I keep. Substance abuse history makes me more comfortable with a PO antibiotic in the aspect of diversion risk. So agree. I mean, and it is a way to get these patients who, once they get some treatment from our substance use disorder team and get started on, medication assisted treatment, gets them out of the hospital definitely sooner. In her case, back to her 2 younger kids. So she was transitioned to linezolid and rifampin for the last 4 weeks of a total 6-week postoperative antimicrobial course. Because her blood cultures had cleared prior to surgery, we didn't transition her to oral suppression. Stopped treatment at 6 weeks. She participated in ID clinic visits at 1, 3, and 6 months after hospital discharge. She completed her COpAT regimen with 100% adherence, no side effects or adverse events, and was doing well clinically and considered cured. And she also had a repeat, transthoracic echocardiogram that showed no evidence of relapsed infection. Her CRP had normalized 1 week after hospital discharge, and at the end of treatment, it was less than 1. Or at her end of her time with us, it was less than 1, so she continued doing well. And she also continued doing well from a substance use disorder standpoint. I guess other things, that we learned, or combination kind of for using COpAT that's unique to this case, right? So the substance use disorder patients, and again, that may be a population that we're even more comfortable with COpAT, and there may be an even greater benefit. She had very, very prolonged bacteremia, right? So over a month, had increased antimicrobial resistance, positive operative cultures. And then in her case, we learned, this is an earlier case, right? 2022, when we started our COpAT program, we were doing more of transitioning after 4 weeks of IV antibiotics to 2 weeks of oral. In her case, we transitioned after 2 weeks of IV antibiotics to 4 weeks of oral, and she did very, very well. And this taught us a lot, kind of increased our comfort with even earlier IV to oral antimicrobial transition for complicated severe infections, to now we're doing it, as in the first case, 72 hours postoperatively. So just a case that taught us a lot that we wanted to share. If anyone has any questions or comments, please speak up.
Thank you. Oh, Dr. Sorry, I see you unmuted.
Yeah, just a question. I think you have long-term follow-up on this patient, right? Patient was seen in 23 as well?
We do. I think since then we do have longer term follow-up. Yeah, I said 1, 3, and 6 weeks or 6 months, which we captured data on her, but we did continue to follow her. You're absolutely right. Over 1 year follow-up on her when she still continued doing well. Thank you.
Any other questions, thoughts from the group? And I'll help monitor the chat as well if anything comes through. Alrighty, well, thank you again, Dr. Jeskowicz. Great cases, really so much information there and really great learning cases as well. So thank you so much for bringing up all those great points and learning materials for the group. If there are any questions you think of along the way, even throughout the didactic, you're welcome to chat them in. We can always have discussion and revisit the cases if anyone would like to. So there's that as well. All right, Drew, if you are ready, I'm happy to screen share and pull up your didactic for you. If you'd prefer to screen share on your end, you're also welcome to do that. I know some folks prefer doing that, so you don't have to keep saying next slide to me, but it's totally up to you.
Yeah, thanks. I will go ahead and share my screen
Sure.
so I can advance the slides, and we have a couple of questions. Oh, I've been disabled from screen sharing, sorry.
Let's see. You should be able to now. Let me see if try seeing if that works now. for you.
Okay.
So,
Everyone see the PowerPoint now?
yes, that looks great on it. It looks like the presenter mode. So if you just swap that, yeah, perfect. That looks great. Thank you so much.
Awesome. Thank you all. My name, as I mentioned earlier, is Drew Ward. I am one of our infectious diseases clinical pharmacists here at WVU Medicine in Morgantown, West Virginia. As part of this echo session today, I'm going to be focusing my discussion on a couple of principles in the treatment of infectious endocarditis. So we'll go ahead and get started. Today, I hope you'll be able to understand new considerations when choosing antimicrobial therapy based on recently published literature for infective endocarditis. The first concept we're going to talk about is this idea of gram-positive synergy. For many years, the IDSA, the Infectious Diseases Society of America, has recommended synergistic gentamicin alongside another agent for the treatment of a number of different indications, including native valve endocarditis caused by streptococci, enterococci, streptococci bovis, and prosthetic valve endocarditis caused by our viridans group streptococci, strep bovis, enterococci, and staphylococci as well. So a majority of gram-positive organisms, when referenced in this guideline, are on their merit believed to be needed to have adjunctive gentamicin therapy. We're going to talk a little bit later about some data and literature that's been published in the past 2 to 3 years or so that challenges this notion. But just as a bit of background on what we mean by gram-positive synergy, in those guidelines I referenced, this is usually a beta-lactam active against the organism of interest, or vancomycin plus gentamicin at 3 mg per kg per day. This is usually divided in 2 to 3 doses. So often we'll see 1 milligram per kilogram every 8 hours, or 1.5 milligrams per kilogram every 12 hours in clinical practice. Some concerns for using these combinations are pretty evident when you consider what drugs we're combining or using alongside one another. So gentamicin, if added, requires therapeutic drug monitoring of its own, which can create some logistical hurdles depending on where the patient needs to have antibiotics, whether that be in the home, or since they do require therapeutic drug monitoring, does the patient even need to stay in the hospital? In addition to that, we're also worried about adverse effects. So specifically, a combination of vancomycin and gentamicin can put patients at risk of nephrotoxicity. Aminoglycosides like gentamicin on its own also propose a risk of nephrotoxicity and ototoxicity, although the latter is not as significant in these lower doses used for synergistic purposes. I added this figure as a little reference to the Super Bowl this past weekend. So it kind of simplifies the thought process of using aminoglycosides alongside a cell wall synthesis inhibitor against bacterial cells. So you can see on its own, gentamicin can't penetrate the peptidoglycan-rich cell walls of gram-positive bacteria. It's not until we have something like beta-lactams or vancomycin that creates gaps in the cell wall that allow gentamicin into the cell where it can act on its ribosomal target, subsequently enhancing cell wall, those gaps in the cell wall and the inhibition of protein synthesis carried out by ribosomes. Looking at an article published about 2 years ago by Ryder and colleagues in the Open Forum of Infectious Diseases, they took a look at 4 different studies, combined their data, and came up with a few conclusions about gentamicin and its use alongside other agents for staphylococcal prosthetic valve endocarditis. Their findings, I'm looking at these 3 studies, 2 of which were from the 1980s, the other 2 were published in the last 5 or 6 years, found that the addition of gentamicin didn't reduce clinical failure in these patients. And as a result, they believe that recommendations of gentamicin should be downgraded in staphylococcal prosthetic valve endocarditis and future guideline updates. So I wanted to briefly, based on what we just talked about, ask the audience, which of the following is a finding of recent literature regarding the use of gentamicin in staphylococcal prosthetic valve endocarditis? That A, gentamicin improves mortality, B, gentamicin doesn't reduce clinical failure, C, gentamicin results in fewer ADRs, or D, gentamicin should be used in all cases of Staph aureus or staphylococcal prosthetic valve endocarditis. And
I'll help you monitor the chat as well.
yeah, I was going to say, I can't see the chat from my side, so.
I got you. We got B coming through from 3 folks. I'll put my vote in for B too as well. Yeah, it looks like
Okay,
a lot
awesome.
of people
Yeah,
saying
it looks
B.
like B may be the consensus among our group based on what I just presented. So yeah, that's correct. Based on those findings of that recently published meta-analysis, their authors concluded that gentamicin doesn't reduce clinical failure in cases of staphylococcal prosthetic valve endocarditis. Awesome. So we're going to take next a look at a similar concept and one that came up earlier in Dr. Jeskowicz's case about adjunctive rifampin and the use of endocarditis. So in those same 2015 guidelines published by the IDSA, they recommend the use of rifampin adjunctively to an active agent in prosthetic valve endocarditis caused by staphylococci. The rationale for this is that rifampin on its own does have inherent activity against a number of staphylococcal organisms, although it shouldn't be used as a monotherapy agent because resistance is likely to develop quickly in that scenario. Even more so, it's known to penetrate bacterial biofilms that are produced by gram-positive bacteria, often implicated in gram-positive infective endocarditis when a prosthetic material is present. As such, you'll see guideline recommendations from the IDSA recommend a staphylococcal active agent like nafcillin or oxacillin or vancomycin, plus rifampin 300 milligrams orally or IV 3 times daily for the duration of therapy. What are some concerns with adding rifampin? Well, the biggest one is, as we touched on earlier, is drug interactions. So many of these patients with valvular disease may require prosthetic valve placement and subsequent anticoagulation using one of the oral anticoagulants we have available to us. Often this is warfarin or in an indication other than valvular disease. We might use a DOAC like rivaroxaban, for example. Additionally, rifampin can cause hepatotoxicity. This has been seen in a number of both initial studies of the drug and subsequent clinical studies looking at combination of the drug. So pulling from that same article by Ryder and colleagues in 2022, those same 4 articles also involved a substantial amount of rifampin use in addition to synergistic gentamicin. And so when looking at rifampin, they found that it was associated with hepatotoxicity, nephrotoxicity, and more drug interactions, and that 31% of the patients treated with rifampin during their treatment course ultimately had the drug discontinued. They made the same recommendation to downgrade those recommendations of the use of rifampin in staphylococcal prosthetic valve endocarditis. Sorry, there's a couple things I did want to point out in this regard. So warfarin as an interaction can be monitored. So we talked a little bit about interactions with warfarin and some of our direct oral anticoagulants. In the case of those DOACs, it's often considered an absolute contraindication to use alongside rifampin. So it really kind of ties our hands when a patient definitely needs to be one of those agents when also considering the use of rifampin. Alternatives include warfarin, which while the interaction is severe, we can monitor INRs to correctly dose the drug. Or patients then might need an injectable anticoagulant as an alternative like enoxaparin. Additionally, some more considerations about rifampin noted in this article and infective endocarditis in general is that ages or the mean age at which endocarditis is diagnosed in the general population has actually increased over the years. In particular, one indication in which rifampin is often indicated, enterococcal endocarditis, that population often tends more older than the average age of endocarditis patients overall. And as a result, they have often more comorbidities and their age contributes to a higher risk of acute kidney injury, which can be precipitated as they found by rifampin use. Looking specifically at one of those studies at the use of adjunctive rifampin included in that meta-analysis was published in 2021 in Clinical Infectious Diseases. This looked at 180 patients with prosthetic valve endocarditis attributed to Staphylococcus aureus. In this trial, 101 patients, or 56% of them, were treated with rifampin. The other 44% were not. They observed no difference in 1-year mortality or infection relapse rates, and also found that rifampin use was associated with longer hospital stay. In general, in this study, a median of 33 days of rifampin treatment was used across those 101 patients. And interestingly, all 180 patients in this study did receive synergistic gentamicin. They also found that the 2 factors that were most associated with 1-year mortality was disease associated with MRSA, or a complication of cerebral emboli present upon diagnosis. So based on that, which of the following is true of rifampin? That dosing for infective endocarditis is 300 milligrams twice daily, rifampin has few drug-drug interactions, or rifampin use is not associated with hepatotoxicity, or D, rifampin use in this indication doesn't reduce clinical failure.
We got a chat
We
in
have
some
D. Okay,
It looks
a
like
few
D.
Ds. Yep. Again, that's just based on this one retrospective meta-analysis published a couple of years ago. But based on what we talked about, yes, D is the correct answer. Rifampin use and this indication may not reduce clinical failure. So we'll talk briefly about rifampin in this next section, my last section of the day, and that's the concept of using oral antimicrobial therapy for infective endocarditis, something that we've already got experience hearing about from Dr. Jeskowicz earlier. For years, the IDSA guidelines published here in the United States have promoted the use of IV antimicrobial therapy for the treatment of bacterial endocarditis, aside from the use of adjunctive rifampin, ciprofloxacin, potentially in cases of gram-negative endocarditis, and say linezolid in the case of resistant enterococcal endocarditis. In general, as Dr. Sawari mentioned earlier, oral therapy is often preferred by patients, and it negates the need for long-term IV access like PICC placement in most of these cases. The landmark trial that was published in 2019 showing that oral antimicrobial therapy often can be used in just as an effective way as IV therapy for left-sided endocarditis was the POET trial. It was published in the New England Journal of Medicine. They randomized 400 patients either to IV or oral regimens after 10 days of lead-in IV therapy. This included patients with endocarditis caused by streptococci, enterococcus faecalis, and both Staphylococcus aureus and coagulase negative staphylococci. 27% of patients had a prosthetic valve at randomization. And what they found was between these two groups, the composite outcome that looked at both mortality and infection recurrence occurred in 12% of IV patients and 9% of patients in the oral arm. So no statistically significant difference, and it was determined that oral therapy was non-inferior to IV therapy. Just a couple of notes. Predominantly aortic valves were involved in this particular trial. Nearly 40% had valvular surgery at the time of randomization, and patients were considered clinically stable prior to randomization. As some of the supplemental information of this study points out, there was a small higher incidence of observed GI side effects in the oral group compared to the IV group, which is to be expected given the route of administration. They also found that incidence of allergy was higher significantly in the IV group than when compared to the oral group. Interestingly, because of likely the location of where this study took place in Europe, there was no MRSA included and only 8 cases of methicillin-resistant coagulase negative staph. Among the oral regimens used, no monotherapy was used, and so that can lead credence to the use of rifampin alongside, say, linezolid or amoxicillin, as we saw in our earlier case presentation. All of the regimens used in the POET trial combined at least 2 antimicrobials with activity against the causative organism. This is a visual representation of different subgroups to see if any particular treatment, IV or oral, favored one or the other. And as you can see, the dotted line intersecting all of the line items on this graph, that no particular subgroup was better suited to be treated with oral therapy versus IV therapy. We begin to see the ramifications of this actually in European published guidelines last year, in which they briefly state that clinically stable patients can end their antibiotic treatment at home with IV or oral regimens for up to 6 weeks duration. And they provide this handy graphic of when to consider switching to oral therapy or outpatient therapy after the initial early critical phase of disease, which will include things like IV treatment, using bactericidal drugs, cardiac surgery if indicated, including the removal of infected cardiac devices and the draining of any abscesses associated with the case of endocarditis. And then at that 10-day point, they do recommend, or 7 days post-surgery, that outpatient antimicrobial therapy, either IV or oral, can be used interchangeably in stable patients. I don't have a question regarding that concept, but would be happy to answer any questions or hear any comments from the group. Otherwise, I appreciate the opportunity to present today.
Thank you so much, Drew, and we appreciate you joining us today and sharing your expertise with us. Thank you so much. We did get a chat in from Gabriel. Thank you so much, Gabriel, for the chat. He says to reduce the frequency of nephrotoxicity and higher cumulative trows of gentamicin, sorry, I'm not a clinician, so my pronunciation might be off, especially in combination with vancomycin, why is not recommended to use it once daily dosing at a dose of 5 to 7 milligrams per kilograms, 4-gram positive synergistic effect. Again, apologies if I mispronounce anything. And Gabriel, again, thank you. You're welcome to unmute and ask it as well. But Drew, I'll turn that question to you.
Yeah, that's a good question. I think it comes down, to my knowledge, as just being synergistic dosing historically has been studied at that's lower, more frequent dosing regimens, as I'd mentioned in the PowerPoint. I am not personally familiar with any case where adjunctive gentamicin has been used at a higher dose administered over extended frequency. But that is an interesting thing to consider. You know, would we observe less nephrotoxicity in these cases of synergy, as has been observed when using gentamicin for a number of gram-negative infections in this way? But I appreciate the question.
Thank you, Drew. And Gabriel, any other questions regarding that or thoughts? Oh, he says thank you. Awesome. Any other questions, thoughts from the group?
I guess my question would be, when you're designing clinical trials, you have to pick arbitrary timelines, right? So they picked 10 days as the minimum amount of IV drug to be used. Does that mean that 7 is worse? Or should we become more and more comfortable with, once we have good source control in the case of a valve surgery and a patient is stable and taking PO medications, it doesn't matter whether it's 7 days or 10 days? Just a question for thought.
I agree, Dr. Sawari. I think the concepts of source control and clinical stability would outweigh, you know, any decision I made or recommended either way, 7 versus 10 days of IV personally, but happy to hear what other people think as well.
Any thoughts from the group?
I agree as well. As soon as the patient's clinically stable, you know, after source control, in this case, surgery, to transition to oral. And we're studying that now, right, through our COpAT trial, where it's randomizing these patients to receive oral to IV antibiotics 2-to-1 to complete treatment. And we've already had a handful of successes with endovascular infections on patients that were transitioned to oral antibiotics early, within that first 7 days sooner, and have done well. Now have three-month data and counting.
Thank you, Dr. Jeskowicz. Any comments from the group, questions? We have about 7 minutes left or 6 minutes left of the session. I don't want to rush anyone. So if there are any final comments, questions about the case, the presentation, you're welcome to at this point. And Drew, if you have any, I know you just did a whole presentation, but if there was anything else you wanted to add before concluding the session, you're welcome to as well. Alrighty, we've got a chat in. Thanks, Amanda. She says, thank you. Very fitting as we have a couple of patients right now. We are adjusting their endocarditis regimens. Thank you so much for chatting that in, Amanda. Happy it was helpful for you. And you're welcome to bring any cases, or if you do have patients with things like this, you're welcome to talk about it at the next session or anytime you would like to. It'd be really cool to see any follow-up or things you learned from the session that you implemented in your clinic. So thank you. Alrighty, if there is nothing further, I believe the next session would be on March 12th. So I think that one will be on major antimicrobial toxicities and monitoring. That's the title we have down. So keep an eye out for that reminder. We look forward to seeing you guys at that session. Thank you again, Dr. Juskowicz, for the case presentation. It's very wonderful. And thank you, Drew, as well for the presentation. We appreciate your time. So thank you all so much. And I hope you have a wonderful rest of your week. All right, take care, everyone.
Thank you.
Thank you. Bye-bye.